Hello, everyone. My name is Anna Wolff. I'm an osteopathic physician who has board certification in neuromusculoskeletal medicine. I usually describe this as a potpourri of things that includes training in neurology, sports medicine, orthopedics, and rheumatology. And I do a lot of gentle hands on treatment, which is called osteopathy, as an addition to the medical management for recipients of my medical care. I started and run Wolff Osteopathic Medicine, which is my private practice in San Francisco. I am also finishing up a brief fellowship right now with Prism Spine and Joint here in Maryland. I live with HEDS myself, as well as POTS, which were diagnosed in 2020 following exposure to COVID during residency. I'm sure that if we were all here in person today, a lot of hands would go up if I asked about whether you'd heard this adage before. If you hear hoofbeats, think horses, not zebras. The hoofbeats in dysautonomia or POTS tend to be symptoms shared with a number of other conditions. Among healthcare professionals, these symptoms of fast heart rate, dizziness, and anxiety are often more associated with a number of issues believed to be more common. However, as this audience knows, we are a veritable safari, and zebras aren't actually all that rare these days. In this case, our zebra isn't just one medical condition. There are a lot of parts making up a zebra, and much like the constellation is made up of many bigger and smaller pieces, so is this set of conditions that we live with. The zebra constellation is my way of describing this collection of conditions that many of us experience. While dysautonomia is the primary star of the show for this conference, it's impossible to talk about it in isolation, and I want to introduce the other notable celestial bodies, hypermobility and mast cell activation. Many people living with these conditions, and some of their healthcare providers, know that when one of these conditions is present, the other two likely will be present as well. As we are developing a better understanding of dysautonomia and the conditions that tend to come alongside it, we are building up data and evidence to back this up. And there is more and more belief that it's not three distinct rare conditions that happen to show up together, but that these conditions are connected. So how is dysautonomia related to hypermobility? I'm using the term symptomatic hypermobility here to distinguish between people who are flexible and are otherwise living a normal life and people who are dealing with significant problems relating to their hypermobility. Among people with symptomatic hypermobility are those with hypermobile Ehlers-Danlos syndrome, HEDS, hypermobile spectrum disorder, or HSD, and a number of other conditions that include other forms of Ehlers-Danlos syndrome, Marfan's, and Loeys-Dietz. In people with symptomatic hypermobility, dysautonomia is common, and this is because dysautonomia is impacted by hypermobility in a few important ways. In a hypermobile person, blood vessels are a little bit more stretchy than in people without hypermobility. And so when we stand up, the blood will pool in the extremities, impacting our blood pressure elsewhere in the body. This drop in blood pressure causes an increase in our heart rate and a lot of those other familiar symptoms we associate with dysautonomia. We treat this in a lot of different ways, including with compression garments, but it is an issue that is inherent to people with hypermobility. Another feature of hypermobility is how it influences our nervous system. This is because nerve endings that help us know where our body is in space, called proprioception, are located in the ligaments. This lack of stability and resulting poor spatial awareness makes us more injury prone and means our nerves are primed and on higher alert routinely to try to avoid us injuring ourselves. Hypervigilance in this context causes an increase to our fight or flight activation, also known as the sympathetic drive, and influences how we experience dysautonomia. In a small subset of patients, severe upper cervical instability can also present with symptoms of dysautonomia. This can occur because of the occlusion of blood vessels in the upper neck, such as the vertebral arteries and the carotid arteries. When the head is turned or extended outside of its normal range of motion, one or both of these sets of blood vessels can be compressed. This anatomical feature is why I always advise against anyone receiving a high velocity technique to the neck or cracking of the neck. And then, how is mast cell activation related to dysautonomia? As many of you know, mast cell activation is quite common in people who have POTS or other forms of dysautonomia. Mast cells produce histamine and other products that are a normal part of our immune response. but they can become activated excessively and contribute to dysautonomia. Why this happens and how in this specific population is still being figured out, but we do kind of understand or have some ideas around why mast cell activation itself is contributing. When mast cells are activated, histamine is one of many mast cell mediators that are released into the tissues. Histamine causes fluid to leave the blood vessels and reduces the overall blood volume. If you've ever been stung by a bee, you know how swollen the region can become. This is due to this phenomenon, and in some cases, it can cause full body reactions. This is called anaphylaxis. In anaphylaxis, blood volume is reduced so much that people may need emergency medical care, like epinephrine and IV fluids. Even in milder presentations without anaphylaxis, this vessel leakiness can impact blood volume and blood pressure. Understandably, this can worsen the impact of our underlying dysautonomia, and is why some people without anaphylaxis may still need IV fluids and medications to help them with managing their symptoms. When you have IV fluids on board, it increases the intravascular volume, and if you have things like salt in that, it's going to help maintain that fluid volume inside the blood vessels. Mast cell-related inflammation also contributes to worsening hypermobility by damaging connective tissue that's already dysfunctional and makes pre-existing instability worse for this reason. But wait, there's more. To continue my constellation metaphor, consider how we see more stars as we have new powerful telescopes and other ways to gather more data. Suddenly, there are a lot more parts to this than originally meets the eye. In my years living and working with the Zebra constellation, I have seen it connect to hypermobility, dysautonomia, and mast cell activation, but also with many other conditions. Some of these conditions include migraine and chronic headache, myalgic encephalomyelitis or chronic fatigue syndrome, immune dysfunction, gastric motility dysfunction, endometriosis, sleep disorders, and PTSD. Not everyone with one of these conditions is necessarily going to have them all, but when a few of these conditions show up, it might be part of a larger picture that could get missed by a specialist who's only looking at one of these things in isolation. I'm going to review a little bit of information about the connections between POTS and other related conditions, but I know that there are a lot more than I can possibly go over in today's presentation. So take this as a sampling that demonstrates some of the many connections. Additionally, I have prepared a list of resources that includes full citations of the papers I'm referencing in this presentation. So please don't worry too much about trying to write everything down. I'm letting you know all of this, so it's not too overwhelming. Briefly, as this topic is going to be covered elsewhere in the conference. MECFS, or myalgic encephalomyelitis chronic fatigue syndrome, as well as many ways in which long COVID can manifest, is defined by autonomic dysfunction, at least in part. This is a direct contributing factor to symptoms of fatigue. When people have difficulties with sitting upright for long periods of time, this can cause issues with fatigue that is made worse by their POTS or associated mast cell symptoms. Diagnostic criteria for MECFS includes dysautonomia as part of its definition. In my practical experience and professional clinical experience, when I've treated patients with chronic fatigue syndrome for their underlying POTS, it often improves their symptoms of fatigue. Migraine is another quite common associated condition. In a 2022 narrative review in Headache, the Journal of Head and Facial Pain, it was a discussion of the connections between POTS and migraine and how different types of migraine issues may be related to POTS subtype. In neurogenic POTS, the increased sympathetic stimuli, our fight or flight, led to reduced function of the vagus nerve. The vagus nerve, among its many roles, acts to suppress the excess inflammatory response. If it is unable to function adequately, inflammatory activation is going to go unchecked. This can lead to pain directly through the nerve irritation, but also contribute to muscle tension and gastrointestinal symptoms like nausea and vomiting. Additionally, the regions of the brain associated with autonomic regulation are also tied to pain perception and central sensitization, meaning that the intensity of pain felt will be worse than the average when one of these three things is impacted. In hypovolemic POTS, the hemodynamic changes in blood volume reduce the blood pressure. When there is a drop of blood pressure in the brain or the head, blood vessels all over the body are going to constrict. This is to bring the pressure back up so blood flow maintains itself to the brain. This process is vasospasm and is thought to contribute to or initiate migraine symptoms in some people when it occurs in blood vessels around the head, the neck, and the scalp. This can also cause chest pain for some patients with POTS when this happens in heart arteries. Sleep disorders are another quite common issue with individuals with POTS. In a 2018 literature review by Miglis and Barwick, they did an aggregate of multiple studies on this topic and concluded the following. People with POTS reported increased symptom severity when also living with a sleep disorder. It took longer for people with POTS, on average, to fall asleep when they tried to go to bed. This is called sleep onset latency. Additionally, heart rate variability is altered during sleep in POTS patients, possibly as a reflection of their hyperadrenergic state. This may also reflect underlying associated fatigue related to ME/CFS. People with POTS, especially the hyperadrenergic variant, often demonstrate a, quote, tired but wired state, also termed the general hyperarousal, which makes it harder to fall asleep even when they're exhausted. This is likely associated with hypervigilance and can be present in psychiatric disorders as well. Specifically, connections have been made between persistent PTSD symptoms contributing to cardiovascular problems, including autonomic dysfunction. This was identified in a 2015 review in the American Journal of Physiology, which looked at the ways in which PTSD influenced heart disease. Among these was autonomic dysfunction. Moving from our rest to our digest of the parasympathetics, the autonomic nervous system also plays an important role in the function of the GI system. In patients with autonomic dysfunction, another common problem we will see is gastric motility issues. In milder forms, this can lead to symptoms of GERD or reflux, constipation, and bloating. When this is more severe, it can escalate to issues around swallowing, nutrient absorption, and difficulties with defecation and gastroparesis. Two studies looking at POTS and gastric motility include a 2020 study from Alomari et al. At Cleveland Clinic, which evaluated hypermobile individuals and found that 38% of those patients who had POTS also had delayed gastric emptying, as well as 14% having accelerated gastric emptying. In a 2015 study with Lovenbroek et al., there were nearly 80% of those who had abnormal gastric emptying in the patients with POTS. Dysautonomia and immunological dysfunction is another area of emerging research. Because COVID-19 has led to a massive increase in POTS diagnoses, studies investigating autoimmunity related to long COVID have found numerous potential autoantibodies that could play a role in the development of POTS. SARS-CoV-2 virus is not the only infectious or environmental agent that can contribute to autoimmune-related dysautonomia, but it is one of the more commonly and currently studied. A 2023 study by L. Raremul et al. Identified a number of autoantibodies associated with and potentially a factor causing POTS. These include G protein-coupled receptors, or GPCR-specific autoantibodies. GPCRs are a common type of cell receptor normally activated to influence cellular activity. They are especially relevant to the function of white blood cells and therefore inflammation. Autoantibodies to angiotensin II receptors may also contribute to abnormal regulation of blood pressure. Finally, structural components of the heart, proteins in this case, were also found to have autoantibodies to them. And these, when impacted, can change the effect of muscular function and electrical signaling within the heart. In turn, this affects heart rate and heart efficiency. While we don't yet completely understand how endometriosis physiology works, more strides have been made on research, and many of us who work in this zone notice that people with POTS, mast cell activation, and hypermobility have endometriosis. Often this is with higher severity due to the immune endocrine impacts. Some research, such as this 2022 study in Frontiers in Immunology by McCallion et al., demonstrated that in normal uterine tissue versus endometriosis tissue, staining with antitryptase antibody found significantly higher numbers of mature mast cells present and endometrial lesion tissue. Additionally, a 2011 study found that reduction in endometriosis symptoms was achieved by placement of a Mirena IUD. This is not surprising to most of us, as many people with endometriosis have already been advised this. However, the interesting thing is that in this study, they also found that the IUD presence reduced the mast cell activity in both the endometriosis lesion tissue as well as the endometrial tissue found normally within the uterus. As we continue to learn more about these conditions and their connections to one another, I hope it may help us physicians and medical professionals see this zebra constellation holistically instead of trying to look at each of these symptoms as problems that should be addressed and prioritized separately. I hope you find this information helpful and empowering. Thank you so much for your attention. You can find me online at the following locations listed here. Additionally, if you're a medical student or resident, feel free to reach out if you're interested in rotation opportunities. Thank you.